Kia ora koutou. My name's Leslie Batten and this is Maureen Holdaway. And together we're going to present some beginning findings about a project which is still underway. And we're presenting this on behalf of the LCP research team, the Liverpool Care Pathway research team, which operates locally. And so what we'd like to do is just present some very beginning understandings about the project and how it's unfolding. And I have to say it's really exciting to be able to present this information. We've started doing this quite early in the research process, and as Simon said, he's one of our research partners. As he said, this is a HRC-funded project, and as a result, normally projects you wait quite some time down the track before you do anything about the results, but because of the way that this project is set up, we've been working on the results and our research partners have been working on them straight away, which is really exciting. So we were delighted to be able to present this to you, and we'll probably have a little bit of time at the end for some questions, and we're happy to answer those, or else you can grab us during the morning and we can answer some of them as well. So we have some research partners, and some of them are here, so it's lovely to see them here supporting our work as well. We have a group from the Research Centre for Māori Health and Development at Massey University. We have the National Liverpool Care Pathway Office, and we have Arahanui Hospice and Te Wakahui Manawatu Trust, one of the Māori health providers locally. And together this team came together. I probably won't go into the dramatic history. I left the country to provide some palliative care for a friend of mine, and came back to find that my darling colleague here had signed us up to joining in a project about palliative care. So that from our side, that was the side, but we were approached, or Massey was approached from Arahanui Hospice and some interest in doing work around palliative care research, and together we looked at what were issues for the hospice and palliative care, and at that stage mid-central as well, in terms of what were key pertinent issues that they wanted to research with us. And at that stage, one of the things was that the Liverpool Care Pathway had been introduced in 2005, and Arahanui Hospice had worked very closely in doing a pilot project with that to evaluate how that was introduced. And the Liverpool Care Pathway, most of you will know more about it than we do, but it's an end-of-life pathway that is used in those last hours and days of life, developed in Liverpool and the UK, and has been proven to dramatically change the quality of care in all settings where it's used, which are outside of it's hospice as well as home, hospital, aged residential care, and in a variety of ways. So it's an internationally recognised best practice tool. One of the things that happened when the LCP was introduced here was that some cultural goals were added. And so it was decided that we would actually research those cultural goals and see if those were working and how they were working with a particular focus on Māori. So these are the research project aims. Over 3 years, we wanted to investigate if and how these cultural goals that had been added to the LCP as a sort of unique New Zealand invention, if they were actually helping guide the delivery of culturally appropriate end-of-life care for Māori within the mid-central District Health Board region. And we then wanted to explore their experiences and perspectives of end-of-life care, of whānau whose relatives had received care, guided by the LCP since those goals had been included. And we also wanted to work in partnership with Māori communities, our stakeholders, providers, to actually develop and pilot a culturally appropriate end-of-life tool or a version of the LCP. So this is a bit of a diagram in terms of the phases. I like phases in projects, and this one has 3 phases, and you can see from here that the first phase was looking at a stock take of where we come from, so what's been happening, and to do that we decided to do a chart audit of charts within the region, looking at charts. We decided to do some stakeholder interviews, and we also wanted to do whānau interviews, and those whānau interviews are underway. The retrospective chart audit was completed last year, and the stakeholder interviews were completed last year, and I'll present some of those preliminary findings. We also decided that we needed to do some groundwork in terms of envisaging what a culturally appropriate end-of-life care would look like for Māori, and that needed to be done with Māori communities and stakeholders. And that is underway, and Maureen's going to talk about that phase. And then phase 3, which is to start next year, is to actually use some translational research approaches so that we can take academic theoretical findings and actually apply them in practice. And we will be going back into working groups and working with a whole range of people to work out what we can do about piloting and developing the LCP tool. So where are we up to? It's been a really fascinating project so far, and my background is as a nurse, but not working in palliative care, and I've been working in health research for a little while, and so we've all become very interested in the way in which tools such as the LCP are being used, and being able to look at charts and see some of the ways that health professionals use charts takes me back to days in clinical practice. But anyway, our chart audit, what we chose to do was we took 100 charts, and we took those charts from 25 from hospice, 25 from home care, 25 from aged residential care, and 25 from the hospital. And we just wanted 100 LCP documents, because this is just a stock take at this stage. And we wanted to audit these really key things. We wanted to see if and how the following were documented. Was ethnicity documented? Was cultural assessment documented, and what was documented? What cultural care was documented under the cultural goals? And we also collected some demographic details, because things like age and sex, diagnoses and care location at the beginning and end are really important to provide some context. So this was quite a quick chart audit, and it was parts of the process were interesting, just to be able to look in terms of what got documented in an LCP document. The document is designed to be standalone so that other medical charts, clinical charts are put aside, and this is the chart that is used. And so therefore this chart should hold all of that information that I should be able to go in as a researcher rather than a clinician and be able to find all of these things in a chart. So let's talk about what we found, and these are just some of the selected findings. I have a good friend who's a statistician who was pleased to tell me that there's this concept called missingness, which is an official statistical term. And we have lots of missingness, especially in relation to ethnicity, so that in 39 of the 100 charts, there was no ethnicity recorded at all. It was just left blank. And that sort of says something, because it means that ethnicity becomes invisible. Now, there's all sorts of arguments about its visibility and how it should be visible and how it should be made visible. But the fact that in 39% of the charts, which is a pretty good whack, there was no ethnicity recorded as an issue. But actually, you can see that it was quite different across different places. So that in hospital, 60% of charts had no ethnicity recorded, down to 16% in home care. The really unexpected finding was that actually out of 100 charts, we only had 2 that related to Māori or Pacific peoples. So why is it? Because we know that Māori are dying, and we know that Māori are 15% of the population, and we know Māori die at younger ages. So why are LCP documents not being used for Māori or Pacific peoples? And we don't know. A chart audit doesn't answer that. We did a check because we wanted to find out and cope with the missingness that was in the document. So we did a check against National Health Index numbers and against the ethnicities that can be recorded under the NHI number, because there is always an ethnicity recorded. If not, you have a chance of recording up to 3. So we actually found there was a tiny bit of variation. Very, very small amount of variation. So actually all the missingness was not about Māori or Pacific peoples, it was actually about European New Zealanders. In terms of cultural needs documentation, there was very minimal. And when I talk minimal, I say very little recorded. Now, part of that may relate to the type of document that the LCP is, because those of you that will know that it uses a type of recording called variance recording, whereby you are making note of things that are more issues and challenges, and where there is a variation to the pathway. So you're not writing lots and lots of details. And in some charts, people have written beautiful stories and you can capture the person very clearly. But in others, the charts were much about being tick boxes, or in this case, writing lots of A's for achieved. There were very, very few variances recorded, but we had something that was fascinating, and I think it comes down to nurses and brains, and I'm not quite sure how to answer this one. We had, when it came to using the variance reporting, there was only 1% of responses in the version where you could write variance or achieved. But in the other version of the document where you could write yes or no, we had 20% of responses got a no. So I'm not sure why people felt more able to tick no rather than variance. And I don't know. There's some psychological issue there that we won't know about. And there was minimal variance reported. So if you put down that there's a variance, you should document what the variance is. And there was very little that was documented there. So lots and lots of stuff in there that, to unpack and to understand. And we are doing some of that in the other parts of the research. We had a few incidental findings as well. Lots and lots of incomplete documents. And we know that about medical records and clinical records generally, that there's often missing information. But there were also inconsistent documents. And I know the National LCP Office has been doing a lot of work trying to get standardised documents, and that organisations should be using the standard New Zealand document. But we did find some differences in documents. There was something interesting in that one of the goals relates to the cultural needs of whānau and relatives. And it was interesting that staff were ticking achieved when it was quite obvious from the other notes that nobody was present. So if you have a family that are not present with a person in a hospital situation overnight, for example, how do you get an achieved? How do you know whether their needs are met or not if they're not there? And it seems to be part of the issue around the achieved variance recording that makes it difficult with cultural needs and with those sorts of things. And from a perspective of an outsider looking at the charts, and you say, well, how can this happen? How can you have all these achieved when it clearly documents that there was nobody else there at that stage? So I'm not saying the family's needs aren't met, but you don't know that they're not met or that they are met. You've got no way of writing it. The one that really surprised us, but for those of you in clinical, it won't be such a surprise, but 84% of the LCP documents were used for people over the age of 65. So, and it was something like 37% were actually over 85. So this is a document that is being used with a particular group of people. And we came up with a strange but even split between malignant and non-malignant diagnoses that differed across sites. So hospital and aged residential care were generally people with a diagnosis of a non-malignancy, and hospice and home care were more related to malignancies. So those were things for us that stood out. So some interesting things there. We then undertook interviews in terms of interviewing stakeholders. And stakeholders were anybody that had used an LCP or used an LCP in their work. So they could be in a number of roles, clinical support roles, policy roles, and we interviewed 40 people, and it ended up that they were around the North Island. When we described the objectives at the beginning, it was much more about this being a project that was in mid-central, and we'd always said we'd keep it localised because we didn't have the resources to be able to do it as a national project. But actually we had so much interest from around people all around the country that we spread our interviewing to get as broader spread of information and experiences as we could. We were actually planning to do the South Island, but the other person involved left their job, and we had snowstorms that meant that we couldn't get down south. So as a result, we've kept it to the North Island for now. So we wanted to investigate what people knew about the history of the development and inclusion of the cultural goals of care into the LCP document in New Zealand, how they thought these goals influenced culturally appropriate care for Māori, and whether these goals were useful. And what we found was that when we talk about the development of the goals, some people had no understanding that they were a New Zealand invention at all. Some people thought that these were what were happening internationally, but other people had very clear understandings and were involved in the development and were able to describe a process that we've called an organic process, whereby people thought that these goals, it was really important that in New Zealand we include culture overtly in a document such as this. And the challenge was that you had to, or the group involved in developing these, had to maintain the integrity of the LCP document so that it could be comparable internationally. So as a result, there was some consultation with Māori locally, mainly clinicians, about these goals that would be included, but it was very much an organic process that went from local adoption here to being spread into the national document, although most people were unaware of how that had happened along the way. And it's actually a really nice story that needs to be written up about the development of these goals. So it was a group of people that saw that culture was really important in New Zealand and that it had to be clear. And as a result, internationally, there's international interest now, and internationally the LCP office, the UK office is interested in the work that's happening here, and there have been some minor changes made in the international documentation to include values and beliefs a little bit more, is my understanding. In terms of stakeholders' perspectives about do these goals influence the care for Māori, came back with some interesting information in terms of clinicians especially thought that the goals were actually really important prompts for all cultural groups, not just for Māori, and that these goals were really useful prompts for people to think about the place of culture in care, and especially in terms of ethnicity. However, we came up with multiple challenges that were external to the goals and actually external to the LCP in terms of providing culturally appropriate care. And these included staff with really divergent understandings about dying and death and cultural understandings in terms of what is appropriate and what could be tikanga. There was varied understandings about what a cultural assessment would entail. So how would you actually talk to somebody about this? And yet there were also many people who provided really wonderful stories about their skill level and their ability to draw on other people in a clinical environment to be able to ascertain information in an appropriate manner. There was very much a focus on talking about family and whānau, and not focusing so much on culture as a word. And one of the things that we found when we talked about were these goals useful were that people talked about sometimes culture being a block, that if you use the word culture, that it stopped people. They got scared about it, they didn't know what to do, and they thought that you needed to have some special knowledge to be able to go any further. And generally people found that the cultural goals were actually more difficult to use in the LCP document. They were much more comfortable with undertaking the assessments related to things such as pain and nausea and those types of things. But we did find that when I talked with stakeholders around the North Island, that because these cultural goals were so overt in the LCP document, that when it was being introduced into areas, that these goals facilitated regional and local Māori consultation, and that it was seen that, again, that culture was overt. But people did expect that there'd been quite a bit more Māori consultation than probably had occurred, underpinning their inclusion in the first place. In a number of areas, people felt that the goals actually reflected practices that were happening in the area already, but that by having the goals included, it made it very clear, and that especially nurses could now document care. They had a place to document care that otherwise they hadn't had a place to document. There were some concerns about variance and minimalist recording, but I have to say that the experienced clinicians I spoke to were much more pragmatic about saying, of course you have to write about the person's story, and of course you have to write about this patient and their family, and of course there's a space in here, you just have to work out where it is. But especially for inexperienced staff, many of them struggled with the idea about where you could put the essence of the person and who they were and what their needs might be in a document that focused on variance and achieved, especially around the cultural goals. And we came across probably the areas that created the most difficulty were that at the stage when the LCP document became a national document, a picture was added on the front cover that was about a fern frond or a panga, and that split the groups. Some people felt that it was appropriate, and some people immediately felt it was an inappropriate icon sort of perspective picture to have on the front of a document about end-of-life care. The challenge related to more about how areas were consulting and whether or not they knew that they could change it. The other thing that became an issue too was that for some people the name Liverpool Care Pathway was a problem, and they felt that we needed a New Zealand name that was much more relevant to New Zealand. And there had already been some work done nationally that was, in some other local areas in relation to thinking about developing their own LCP type document in New Zealand that would have had its own name. So some of that built on that. So in terms of this first phase, we have some early recommendations that are already being worked on regarding building on regional and especially local best practices for clinical education and support. And there's some excellent work been happening, especially locally in the Manawatu region, around supporting staff and using the LCP document, but especially in understanding about working with whānau and patients about their cultural needs. And so we need to build on that rather than reinvent the wheel. In terms of the ethnicity question, in New Zealand we talk about the standardised census question about asking someone about their ethnicity. And so we've recommended that that be put into the LCP document, and also that staff are taught about using that as the question to ask, because that makes it very clear that you can have multiple ethnicities, but it also makes it easier in terms of staff using that, and work is happening around that at the moment. In terms of translated resources, especially for this was not only for Māori but also for people who had English as a second language. There was that need was recognised. Clearer guidelines were needed in terms of the fact that organisations could make some changes in the LCP document and what were the changes that they could make, and so that work's already underway. In terms of prompts, resources and mentorship regarding cultural needs assessment and culturally appropriate care, and that discussions are underway in terms of that, and more of that will arrive once we get further down the track with this process. And we've also suggested that there is reconsideration of the variance reporting for cultural goals, because it doesn't sort of fit to say achieved or variance. So in terms of next steps, at the moment we're doing a revised phase 1C, which is actually about doing a bigger chart audit to see if we can answer some of the questions. So I'm in the middle of re-auditing every LCP that was used in those 4 organisations to see if we can answer some of the questions about missingness and to answer some of the questions in regards to the age gap. And at the moment, I have to say, having done 253 charts, I think our initial findings are holding. But that was worthwhile, and we were able to do this within the chart. And so that's underway. And so now I'll hand over to Maureen, who's going to talk about phase 2. So thank you.
Oh, kia ora tātou. As Leslie says, we've been very busy for our first year, and we are just moving into the second year of our funding and phase 2. For phase 2, we can't really flick back to that early thing, but it's really about starting for us with a blank page and going out using the networks that we've already established in phase 1, working with our Maori providers, Maori cancer navigators, Maori managers and DHBs, and just our connections throughout the local Maori communities and regions, especially within the Manawatu or mid-central district health board areas. For this phase, we really did want to just go out and consult, not around the LCP audit tool per se, but really just simply asking the question, what do Māori whānau, Māori communities, Māori health providers, etc., see as their needs for culturally appropriate end-of-life care? So it is very early on at the moment. We have employed 2 Māori health researchers who are now working with the stakeholders and providers to bring together a number of providers, whānau, people who have been involved with people, whānau at the end of life, people who haven't, right across the age groups. And at this stage, we've only done 3 focus groups out of our 8. And the findings, even so, that people have been very forthcoming, if you like, very happy. When we thought this is a very sensitive area, this is a difficult topic, how do we get people involved? It's not a problem. They want to be talking about, they want to be doing this. They are very forthcoming. And certainly last week we were at Hui Whakapiripiri and one of my researchers texted me because she'd just had her first focus group. Oh, thank you so much for getting me on board. Thank you so much. Oh, this has just been the most awesome project I've ever done. And she was running home to her husband and saying, right, we need to organise this and this because I am really on a roll here, and I'm so involved in all of this. And just the enthusiasm and the feedback she got from just her first focus group, or hui, with whānau, and this was just with whānau, and she was just, it's like texting flat out, thinking, oh, great, good start. So just like Leslie said in the beginning, once this project was funded and the advertising went out, all of a sudden everybody kind of wanted to be involved. But the limitations of funding, even though, as Simon says, it's a substantial grant, it's been difficult. We've tried to involve as many people as possible. We will be doing at least one sort of slightly outside the region because, again, Whanganui have expressed an interest in also being involved, certainly in this phase 2, about how we provide culturally appropriate end-of-life care for Māori. So basically that's where we are up to at the moment, and it's really been quite good because the next presentation also is around Māori health literacy and palliative care, and we've worked in different forums with this group as well, and certainly with the advanced care planning and Tess Walker Maxwell's work on her postdoc is looking at the end of life and whānau stories about how Maori go through that palliative care end-of-life process. Her project is nearly coming to an end. She'll be writing up her final things at the end of this year, but having talked to Tess as well and listened to her presentations and stuff, she's had a lot of whānau again wanting to be involved in trying to look at how we can improve services and access and communication and all of these things, for whānau at the end of life care. And it's probably reassuring that a lot of the stuff she's talking about is exactly the same kind of stuff that is actually coming out of our research. So it's building on this whole research or evidence base to support some changes, as Simon says, for how do we access better, more appropriate care for Māori at end of life. And that's where we're up to. Thank you very much. And thank you, Leslie, for all your work in phase one.
We will take some questions. We have plenty of time. Joe will roll around with the microphone. Please wait until that arrives.
Good morning. Thank you for that. It was very interesting. I understand the difficulty when we are looking at the multicultural society we live in. But what actually I was interested in, did you notice that about the impact that the multicultural medical and nursing and support teams, their multiculturalism had on the effect of what was recorded and their ability to make those sort of decisions?
I'll answer that one from having looked at a number of charts. One of the things that stood out last week was when I was looking at some charts, and it had ethnicity white recorded, and I thought, oh, am I back working in Africa again? And it was quite clear that this was a person working in a culture that was not their own. Many of the stakeholders that I interviewed talked about the challenges of working when English was not necessarily their first language, when New Zealand was certainly not their culture of birth or their area of birth, and how their ideas, for example, about the interplay between religious understandings and cultural understandings were quite different. Even understandings about death and when was it appropriate to withdraw care, when was it appropriate to refocus care on end of life. Those sort of things stood out quite clearly in the stakeholder interviews. But it was interesting when we looked at the way that ethnicity had been recorded in terms of there was a little wee gap, like this big for people to write and what people had written. And so there were many times where people wrote European New Zealander. And I thought, who would reply that if I asked them? Because in New Zealand, the standardised ethnicity question is based on people asking the person themselves to self-identify. And if the person cannot answer, that you ask their next of kin relative about how would this person identify. So that's best practice. But it was quite obvious from a number of the responses that I don't think most people would say, I'm a European New Zealander. They may come up with other things. We did find that in hospice, I think it was clear that people had been asking more because we had more responses which were around being a New Zealander. And Statistics New Zealand has been doing a lot of work because the way in which New Zealanders have started to say, I'm a New Zealander or I'm a European New Zealander or I'm a New Zealand European, that has been seen as the development of a new national identity. And so a lot of work has been done around how does Statistics New Zealand cope with it and our census data. But I think it can be used as a proxy of when people are actually asking, when you get that type of response. So it was interesting to look at just that little gap, but certainly there were some hints about the ethnicity and the cultural background of other people when you looked at it. Yeah, thank you.
Thank you, Leslie. Thank you for an excellent presentation from the team and a very interesting study. My question relates to your clarification around home care. Where did the documentation come from home care? Was it GP practices, district nurses' documents?
District nurses.
Any more questions?
Hi, my name's Brian Ensign from Wellington. I'm aware that just recently the versions of as the LCP versions change, there becomes more of an emphasis that the family are on side that this patient is dying, and therefore there's more of a conversation, and maybe there's a culturally influenced language that's used around somebody that's dying that doesn't include dying. And so does this mean that some cultures are less likely to be on the LCP now because that's not within their the way they talk about things? There's just a query really. And a little comment that the assumption that the LCP is a standalone document is really an assumption, and I am not sure that what you're using it for as a research tool is what the clinicians use it for as a pragmatic document.
Yes, we certainly did look at the versions, and we looked at the some charts were version 11 and some were version 12. And so we looked at the charts that had been used since the LCP had been put in place. As clinicians, you'll be the ones that will be able to answer it in terms of the way that it may be used with different groups when those discussions about dying and the word dying may or may not occur. In terms of us using it as a research tool and not the way clinicians would use it, all I can say is that we then ask those questions back to the clinicians and say, well, why would you ever anticipate that you would copy, for example, everything from one record onto another? But the way that the LCP document is discussed is that it is a standalone tool, and therefore that's the way that we have critiqued it. But in our discussions, of course, we take account of the fact that this is a tool that follows on from care, and I wouldn't anticipate that you would ignore every other discussion that's been had with a family and then say, oh, we'll now start again because we have this tool in place. That's illogical, and I'm surprised, for example, that in some areas where they're using electronic documents that they don't have an electronic follow-on, that it's just not a complete follow-on along the way. But in terms of this research, it's about us putting the picture together, and so using the ethnicity just as one pointer is just one proxy that we then put in place with the other discussions around cultural care and how that fits together, and the discussions with the stakeholders and the discussions with whānau. So it's only one little part of the picture, but at the moment it's the bit that we can pick out and pull apart. So,
Kia ora, Lynn Hoskin, Tui ora, New Zealand Māori. What I wanted to ask was, in regard to the ethnicity question around whether they're Māori or whatever, I think for some Māori, being when they're asked about the ethnicity, sometimes Māori is not enough because it just makes them part of everybody else. Yeah. And for them, the importance for them would be the land where they come from, which would be their iwi. And that would be sometimes more important than actually stating that they were actually just Māori.
Yes.
You know what I mean? Is there, would you be looking at something like that too? In some cases, that's more important to them, the iwi, or even hapu.
And certainly I can remember very vividly one interview I did in which one of the clinicians spoke very clearly about the way in which identifying with a Māori person and their whānau, their iwi, was the most important point, and that for her that was like a flag that there's all these other things that we will be able to work with and work from as a result of that. And so that's been the key part of getting the stakeholder interviews, which were qualitative in-depth interviews, was that we've been able to capture some of those stories that provide much more information than whether or not you decide how you fill in that. But thank you for that. Yeah. Yes, definitely. Yes. Yeah, and that's one of the key things is that, because we're only really working, we will have to pull the project back into this region, that what we're doing is documenting the processes that we are using and the stories that we are gaining from people that other areas will be able to say, is that a process we will use when we start making changes here, so that they can consider some of those things, because we also have lovely stories where local iwi have been working with a hospice and providing a lot more support in terms of what are the cultural practices relating to which iwi in this area for these people, and how do we put those in place, and how do we have a partnership approach to those happening. And those sort of stories are what we hope clinicians will then be able to use in their own areas.
Sorry, I'm not sure if I'm loud enough, but I'll have to go. Fascinating, absolutely huge array of information coming through in those findings, really broad. I guess in terms of, I think of nursing and professional practice and where we've come from in terms of cultural safety in New Zealand, is there going to be some dialogue further along in the recs around that transition from learning into practice in terms of curriculum development?
Yes, I hope so. Coming from a background in nursing education, I definitely hope so. And considering it's now 25 years of cultural safety in New Zealand, then it's, I think, quite timely, because in some ways some of this is a challenge in terms of the fact that we seem to have missed some of the cultural sensitivity education along the way. We seem to have leapt to cultural safety, and there are some steps before that were spelt out quite clearly by Arahapiti Ramsden that I think in some ways we've missed. And so, yeah, we're holding on to that, but in terms of how that can go forward with nursing education as well. And with ongoing education for clinicians in terms of that work as well.
If we can just have this one last question.
Thank you. Roger from Cranford Hospice in Hastings. Just a word to throw into the mix, ancestry.
Yes.
In the States, a lot of documents have ancestry. I think when we work in a bicultural context here in New Zealand, we have a smaller view, but if you come from a truly multicultural society like the States is, ancestry is a useful word. And for Māori, it gives them the opportunity to identify the iwi affiliations, and for non-Māori to say, these are my people, these are my roots, these are where I'm from. So.
Yes, thank you. I agree.
Right, please join in thanking our visitors.